Thank you. Thank you very much.
We'll proceed further, and now we'll have the third talk with Professor Sarad Vyas. To introduce Dr. Sarad Vyas, he is currently the Director of Emergency Medical Services of Gujarat, being a former HOD of Surgery and Emergency Medicine at Vijay Medical College. He is a thorough experienced person in pre-hospital care as well as in hospital care. And Gujarat is the first state to enact the EMS law. A lot of work has been done in this regard. Let us see from the Dr. Vyas that what is being done.
Yeah, good afternoon. I know that it is a difficult time for you to stay awake after such a luminous lectures which has been given by two previous speakers in my session. From Gandhi, seen in the last slide, I start with the Gandhi only because I come from Gujarat, and we are lucky that our Chief Minister is now in Delhi from Ahmedabad, so we have exported our person over here in Delhi. And why I'm telling you is that because the Gujarat has given such a wonderful leadership in the field of emergency medical services is only because of him. Because if the political leadership has got some kind of ideas which they accept for the common good of people, then that is always an acceptable one. Friends, we have two distinct things as a state in EMS. First is that our is the only state which has passed a legislation way back in 2007, and that is called as the Emergency Medical Service Act, and under which we have followed almost a American European model, studying it properly and then making it suitable for our needs, our requirement. And some wonderful things came out, which is for the Indian context, it's very well for us to know. And the second thing is that immediately once we realize that what is EMS, who will play the leadership role, the two institutes of Gujarat became the first institute to produce a postgraduate qualified, MCI recognized postgraduate student of emergency medicine. So in two ways, we are the first to do so in India, and that is how we command a leadership role. The lesson we learn, that is why I have been given a topic, and this is very hard, you know. Well, those my foreign colleagues who are there may not be knowing from which place I am coming. So that is the most western part of India. And if you look at the epidemiology of my state is that we have got 6 million populations. We have got area of 196 square kilometers. The density is about 308 people per square kilometer. We are at present operating 536 ambulances, and that means for almost 1.1 lakh population, we have got one ambulance. Of course, internationally, there is no data which says that how many ambulances per population should be available, but roughly we have already reached that saturated point. And this is the map which shows you that 536 ambulances has been posted in the whole state of Gujarat. And these, all of them are governed and controlled from only one center. Many of my Australian colleagues have visited our centers, and they are highly appreciating about that. Well, friend, we paid a very heavy price to learn the lesson, and state faced multiple disasters in last decade. And these wounds are still not healed, and that is the passion which drives us to develop our things over there. Everybody knows in 2001, Gujarat suffered a severe earthquake. We lost about more than 13,000 lives. The whole state was affected. I'm not talking about the amputees or the paraplegics. Like as we talked, rehabilitation, 74 patients still are rehabilitating from paraplegia because of spine injuries. Then in 2002, we have riots, post-Godra train burning and all that, and that resulted into which more than 1,000 lives lost. And thirdly, our temple was attacked by the terrorists. And again, we lost 37 lives, and we operated about 40 patients in 8 hours of time. And that was really testing our emergency capabilities. And then came the serial bomb blast in our city. And that also lost 49 people of life. And that was a challenge for us. And we took up this challenge and thought that we have to develop some kind of system in some way. These are the victims, from a few days old child to a BSF to a black commando. These are the people whom we treated after the terrorist attack. And these all gave us a lot of understanding about how to evolve an emergency medical system for our state. And this is the worst scenario which we have. An ambulance came inside the trauma center itself, where a terrorist wrap up those bombs around a gas cylinder. And as he was traveling in an ambulance, we could not prevent him from entering into a trauma center itself. So he entered it, and then he blasted it from going away from that by his mobile phone. And that resulted into a tremendous bomb blast inside a 4-story trauma building. And this is the first time that a disaster has occurred inside the hospital where this center was providing. And really tragedy was that two of my residents, orthopedic and his wife, she is a gynecologist and she was pregnant, and both of them lost life. And the tragedy was further contemplated because the people who were working right over there, they saw that near colleagues who were working with them since years were found dead right in their presence. And in spite of all that, they continued to do the yeoman's job, that they kept on treating those patients who were serious. So then we realized that this is a different challenge, that if your trauma center is attacked, then what you are going to do? I mean, nobody has these answers that how to protect the trauma centers which are providing the emergency services. And these are the pictures of the trauma center which has been blasted. And because the police took a immediate sense and they stopped mobile network immediately, and that's why the second part which is shown having some cylinders, that was the second bomb which was there and which remained without blast because a timely action was taken. The operation theater in the trauma center itself was also shattered, so we have to create an immediate other facilities right inside the hospital to cater those people who were there. So what lesson we learned? That means we must have a system to manage such kind of problems. System should be easy to apply, should be relevant to our needs. We can't have a paste, copy and paste kind of mechanism. It should be timely implemented, and it has to be a protocol based. And what it requires is that what are the problems in our present system? And we again realize this is also an opportunity because press and people are facing and questioning the politicians, the bureaucrats, that what is to be done, and that we realize that this is the right opportunity to push our work with them so that we can get a favorable results. And that was the reason why we could get a trauma center and this Emergency Medical Service Act. We presented that to our Chief Minister at that time. So we study what were the problem in pre-hospital care, because that ambulance which was not registered, had it been the law over there, that ambulance has to register with the EMS authority and the numbers will be displayed and only those vehicles would have been allowed inside the trauma center. But because this ambulance was not registered, because the law was not existing, that's why that entered into it. So that's why we said that we must have this kind of legislations to control these kind of mishaps which are there. So there was no call number. I mean, there was no emergency call number by which you can call the emergency. It was 100 number which usually police people take it, and they are not medical people to do that. We don't have designated ambulances. It has been rightly emphasized by my previous speaker that they were only transport vehicle. Then there are no trained persons inside the ambulance. We always say that they are stretcher bearers only. They lift the patient and put in the vehicle and then go away. They are poorly equipped. There is nothing like a life-saving equipment inside the ambulance, we know. No unified coverage of distribution, like we have now a network of the ambulance which covers the whole state. There is no central controlling monitoring, because this central controlling monitoring helps us when there are disasters or there are mini mass incidences, and that we have proven that has helped us to mobilize other ambulances from other places to be placed at the place where the disaster has occurred. So no unified coverage, no central control, people faith in the system was not there, because even if you call 100, but nobody will come and they know it and they will take the public transport and try to go. And concept about air ambulances and boat ambulances were almost unacceptable or unthinkable. People never thought that this could be there also. The hospital scenario know better than that. I mean, as we know that many cooks do the things, plastic surgeon will come, neurosurgeon will come, but the patient will be there, and nobody talks about the emergency requirement, life-saving, stabilization, all those things were absent. So they were shifting the responsibility. There is no single place of management. Many hospitals has gynec emergency different, pediatric different, burns different like that. We don't find a single window where you get this kind of things. Life-saving equipments were inadequate. Time was consumed in managing the patient, so time is usually directly responsible for the life loss. So we found out that the system has to work in a timely fashion. And there are no expertise to manage acute resuscitation. Till today, there is no medical curriculum which taught our students how to perform CPR. This is the tragedy of our curriculum also. So we found out all this kind of a problem which are existing. We do compartmentalized kind of a treatment, not in a comprehensive manner. There are no protocol-based management. Everybody individually thinks that this is my protocol, I do like this is your protocol, you do like this, like that. There are no diagnostic or therapeutic facilities which are available, and concept of golden hour was just coming up, but people were not doing, and it has been already emphasized that the junior persons were managing emergency where very critical decision has to be taken by the senior person if it is there. So then we found out that there are 5 ways by which we can go ahead to develop the system. We have to establish pre-hospital care, we have to update our hospital emergency department, we have to start postgraduate medicine in emergency medicine as well as in trauma. Training at all level, very well emphasized by my previous speaker, community, paramedics and doctors, all of them required. We have to establish process and protocols and document, as Gerard has said, that data has to be there, which was also lacking.